Thank you, Beth. Thank you, Heidi. Thank you, Tina, for inviting me here today. I'm very excited to be talking to everybody about a very important subject, contrast-induced nephropathy in the cardiac cath lab. I have nothing to disclose. So before we get started, I thought we'd talk about our goals for the day. There's a lot of nurses in the room. I think a lot of us like to have goals for our patients, goals for ourselves. So today we're going to first define contrast-induced nephropathy and identify some plausible differential diagnoses so we don't jump to any conclusion. We're also going to identify the patients who are most at risk for contrast-induced nephropathy, and then we're going to utilize some evidence-based practice in the prevention of contrast-induced nephropathy for our patients that are at risk. So before we move on to our goals, let's think about why we're actually talking about this. It's going to be important to know why we're choosing to discuss this today at the symposium. I'm going to discuss this both as contrast-induced nephropathy, but you'll also hear me use CIAKI, which is contrast-induced acute kidney injury. Same thing, different language. So when we're looking at the epidemiology of CIN, we should consider that it's the third most common cause of new AKI in hospitalized patients. That comes just after decreased renal perfusion and patients who've had nephrotoxic medications. It was responsible for 11% of cases of patients with new AKI. Risk factors for these patients include likelihood of pre-existing renal impairment or combination of CKD with diabetes, CHF, advanced age, and administration of nephrotoxic drugs. Patients with CIAKI are at risk for early or late cardiovascular events, prolonged hospitalizations, and death. So let's move on to the definition of contrast-induced nephropathy. Seems like it could be simple. However, there's a lot of different definitions that are out and about, and people have a bit of a labile definition of contrast-induced nephropathy. So the Kidney Disease Global Outcomes Clinical Practice Guidelines for an Acute Kidney Injury defines this as a rise in serum creatinine of greater than 0.5 milligrams per deciliter, or a 25% increase from the baseline value, assessed at 48 hours after the radiological procedure. So we have an increase of either an absolute or a relative creatinine increase, and we have to have a certain timeline, 48 hours post-procedure. This creatinine generally peaks 3 to 5 days after exposure and returns to baseline within 1 to 3 weeks. I think that's important for us to note because a lot of our patients now are going home same day. Most of them are going home the next day. We're thinking about length of stay for our hospitalized patients and moving people along. So we don't even know if this is happening to some of our patients if they're not being assessed shortly thereafter by their primary care physician or their primary cardiologist. Some alternative definitions that are available for us include a 25% relative increase, the 0.5 milligrams per deciliter, which is an absolute increase in serum creatinine within 72 hours of contrast exposure in the absence of an alternative explanation. This is important because we're looking at both the increase, a different timeline, but now we have a diagnosis of exclusion. What can we say it's not? It's not responsible from something else. Another proposed severity grading system has been discussed. This identifies a change in both the absolute and the relative rather than one or the other. And that's actually increased with long-term adverse outcomes. I have a table here that discusses this grading system that was created. You can see grade 0 requires both the absolute and the relative increase from baseline. The grade 1, same thing. And grade 2 is only absolute. This actually looks at our outcomes. What is our MACE? What is our mortality 6 months down the line? So because we have a lot of different definitions, we have to choose one that we're going to use. And we'll use the initial definition that I gave you, which is 48 hours post. So there's a lot of criticisms about these different types of definitions that exist. The major criticism is that we only are looking at one rather than both, rather than using a combination of both the relative and the absolute serum creatinine changes. that we see in the AKI guidelines. There's also an absence of a functional assessment. Functional assessment meaning, are there changes in our patient's urine output? Is the patient urinating? Are they not? Are we using any sort of diagnostic criteria excuse me, I lost my train of thought. The rifle criteria that has the risk, the injury, the failure, loss of kidney function, and end-stage kidney function. So the AKI guidelines are much more specific than the contrast-induced specific guidelines. Serum creatinine relatively is very insensitive also for our patients with a normal baseline function when you compare that to how rapidly a GFR is changed in AKI. For some reason, we still have not adapted the GFR in our CIN patients. So a few differential diagnoses to think about, because I think one of the major things that the whole team needs to think about, not just the interventional cardiologist or our fellows or our primary care physicians, we have a whole team. We have techs, we have nurses, we have nurse practitioners, we have PAs. You have someone walk in the room and say, well, this is contrast-induced nephropathy. Is it? You know what the diagnosis is. You know how to define contrast-induced nephropathy. Is it really an acute kidney injury? Did the patient recently get their contrast load? How recent was that? An atherosclerotic renal failure. We will see a patient that has had contrast. However, those patients have had that contrast a week ago, not 48 hours ago, not 72 hours ago. The pathophysiology of the atherosclerotic renal failure actually has to do with catheter manipulation. So when our catheter is inside of the arteries and they're being manipulated, you can disrupt small plaques. Those small plaques can move around, lodge themselves into renal arteries, causing kidney failure. The kidney failure for our patients with an atherosclerotic renal failure have much poorer outcomes, usually a much longer trajectory of their pathology. We also see patients who may come in with acute interstitial nephritis. We have a triad of 3 different things you should be looking for in these patients. That's fever, a skin rash, and eosinophilia. You also may find some eosinophils in the patient's urine. These patients usually have acute interstitial nephritis secondary to drugs such as penicillins, cephalosporins, or NSAIDs, rather than contrast specifically. And lastly, acute tubular necrosis. Acute tubular necrosis can be defined as ischemia from a pre-renal cause. That's a hypovolemic state. A lot of our patients who are coming into the cath lab may be hypovolemic. They may have edema states such as CHF or coagulopathy such as DIC. So all of those things can contribute to acute tubular necrosis, should be considered rather than jumping directly to contrast-induced nephropathy. So I think most people already know that there's not necessarily a treatment for contrast-induced nephropathy. So our biggest thing to think about is prevention. And to prevent, we first have to assess who is at risk. Our first and most risky patients are those who've had a prior kidney function impairment, those with chronic CKD, someone who's had AKI in the past, for various different reasons, and of course those who've had contrast-induced nephropathy from a prior radiological procedure. Other risk factors include diabetes, hypertension, CHF, advanced age greater than 75, volume depletion, hemodynamic instability, use of those nephrotoxic medications I already mentioned, interballoon pumps, and a large volume of a high osmolarity of contrast agents. There does exist a risk assessment tool, which, interesting enough, one of our Mount Sinai physicians, Dr. Roxana Miran, created back in 2004. It's a very simple tool. You can find it online. It's easy to use. And that's actually a prediction tool to tell us if our patient is at risk post-PCI for CIN. There's 8 variables, all of which get a different integer. Is the patient hypotensive? Defined as a systolic blood pressure less than 80. Did we use an intra-aortic balloon pump? Does the patient have congestive heart failure, CKD, diabetes, and age greater than 75, anemia, and what's the volume of the contrast? I think that you probably can see the parallel from the last slide. This was done in 2004. So one of the questions I thought and asked while I was preparing this for everybody was, is it still relevant? Do we know if it's still relevant? And in fact, there was a study done just in 2016 where a group of physicians went through and they looked to see if this is still relevant. And in fact, it is. They're still using it, and it's in our guidelines, both for acute kidney injury and for the contrast-induced AKI. And Dr. Moran actually published a new article just 2 weeks ago, May 30th, in the New England Journal of Medicine, with an update on her thoughts about contrast-induced nephropathy for our PCI patients that I would urge everybody to take a look at. This next slide just shows us what sort of score the different risk factors get. So our hypotensive patients, our CHF patients, their risk factor is higher than someone with just anemia. And that contrast volume, the number that is assigned, the integer that's assigned, changes based on how much volume we're using. So for the operators, that's how much volume are you injecting? Are you really thinking about it? And as the RNs in the room, as the technicians in the room, continuing to remind the operators, let's protect our patients' kidneys. It's very important. We all have a role. Getting back to that teamwork that Beth was speaking about earlier. So in terms of prevention of contrast-induced nephropathy for our patients that we've already found to be at risk, the first thing to do is make sure we're taking a good history, a good physical, and really reconciling those medications. And that's the whole team. Every person who goes into the lab, you ask them the questions, you look at the patient. Hold nephrotoxic medications, and then IV volume expansions. That needs to be with either an isotonic sodium chloride or a sodium bicarbonate solution. Excuse me. This is important because a lot of times we'll hear people say, well, just have them drink some extra fluids, Our at-risk patients, guidelines tell us that that's not enough. We really do need to give them volume expansion with IV fluids. The guidelines also do suggest that we continue to use Mucomyst paraprocedurally. There's been a lot of data about this, and they can't say that there's any risk to use it. You should not use it as monotherapy. Everybody should be getting that IV expansion. The limit of the contrast medium, and use either an isoosmolar or a low osmolar ionated contrast medium. So when we're selecting our IV fluids, we should use normal saline or sodium bicarb. Sodium bicarb has been not as available, so we're usually using the normal saline 0.9%. The volume can be guided by different things. There's been quite a few studies about this, and actually, they don't give us something specific. The LVEDP guided therapies do offer some good ideas for our patients with CHF, and then the renal guard actually suggests going for a high urine output with a lot of volume being put in the patient, but also with a low dose Lasix drip. So you have to really balance the risk and the benefit there. In terms of when and how much, the suggestion is 1 hour prior to our contrast load and 3 to 6 hours after. There has been found a lower associated risk of AKI paraprocedurally for our patients that have a urine output of greater than 150 mLs per hour, 6 hours post-contrast. You really do need to put a lot of fluid into your patient to get that to happen. So obviously that's a bigger challenge with our CHF patients. And as I mentioned before, we're not going to just give an oral replacement. We need to actually give fluids too. So Mucomyst, oral N-Acetyl. Everybody says it's not, we can't prove it. Why are we still giving it? The guidelines actually do say, let's keep using it. It's not causing any harm. There was a multiple meta-analyses performed to explain the utilities of these medications. Most of those studies were small. 7 out of 11 of them show a net benefit. So at this point, continue to use it with your fluids until there is some more definitive evidence, which it simply seems like there won't ever be because they've done a lot of studies and no one's ever been able to prove yes or no. In terms of our contrast medium, the risk of CIN is higher for patients receiving an arterial administration versus a venous administration. So our PCI patients, the risk is much higher than if we're sending a patient for instance, a CTA. We need to use the lowest dose of the medium possible, both in volume and in the concentration. So that's picking the right contrast dye and giving as little as possible. You should be thinking about what are the procedural strategies? What angles are we taking? Are we doing an LV gram on a patient who has CKD for no reason when we already have an echo? And taking a moment, analyzing the picture that we have prior to moving on and taking the same picture in another way, really taking the time in the lab to make sure we're taking as few pictures as possible. And then lastly, use isoosmolar or low osmolar contrast media. Most of the studies that were done do not say one is better than the other. However, everybody says do not use the high osmolar contrast media. I don't even think they're really out there anymore. Oh, and that's it. Thank you.